Good morning. I love the way you guys jumped in the middle. All right. You guys are not going to be happy that I get a microphone because every time I get a microphone, I feel like singing. Would you like to hear a song? Another day. All right. It is my pleasure, Dr. Nadim here, and my honor to introduce someone who is a former intern of mine about 425 years ago. And it's great to be part of a full circle, to come full circle, where I can honor him today. Before I do that, though, I've been asked to please remind you guys, do your evals. They're important. When you evaluate us, we can be better. We want to provide a better educational experience for you, and we don't know what we're doing wrong unless you tell us so we can stop, or what we're doing right so we can do it even better. So please do your evals. It matters. We actually read them, believe it or not. All right. So again, it's my distinct pleasure to introduce Dr. Paul Thomas, our speaker today. He is a board-certified family physician, family medicine physician, practicing in Southwest Detroit. His practice is Plum Health DPC, a direct primary care service that is the first of its kind in Detroit and Wayne County. His mission is to deliver affordable, accessible healthcare services in Detroit and beyond. He has been featured on TV, WDIV TV Channel 4, Flashpoint with Devin Scillian, WXYZ Channel 7, Cranes Detroit Business, and CBS Radio. All the things I know you're not watching because you're so busy. He has been a speaker at TEDx Detroit, as well as a presenter at the American Academy of Family Physicians Direct Primary Care Conference and the Michigan Academy of Family Physicians Annual Conference. Dr. Thomas is a graduate of Wayne State University School of Medicine and is a clinical assistant professor. In 2018, he was honored as a Vanguard Award recipient by the Detroit Young Professionals, as well as the recipient of the recent Alumni Award by Michigan State University's College of Natural Science. Finally, he is the author of the book Direct Primary Care. This young man has written a book, and it's called Direct Primary Care, The Cure for Our Broken Healthcare System. Dr. Paul Thomas has cured our healthcare system, and he's going to talk about that magic cure today. So please join me to put your hands together for Dr. Paul Thomas.
Wow, thank you. Thank you, Dr. Nadim. That was a warm introduction. I like that. That's cool. So how's everybody doing today? Great. Thanks for taking the time away from your busy rounding and ward work to come through and talk about this. This is actually, I modified this presentation from the Michigan Academy of Family Physicians Conference. I gave this over the summer. It kind of sets out my ethos, and it has some social proof in here. I do have some disclosures. I started the direct primary care practice, and I wrote a book about this subject. So those are my financial disclosures. And in this talk, I really want to talk about defining what direct primary care is. Has anybody heard of this concept, direct primary care? Maybe a handful of hands, maybe 5 to 10 people. Okay, great. We're going to define it. We're going to identify and describe successful DPC practices in Michigan, regionally, and nationally. We're going to identify some barriers to this direct primary care model and then demonstrate concrete steps to overcome these barriers. All right, so just a little bit about me. I had a great introduction. I'm just going to add some photos to this as well. But I practice in Southwest Detroit, just on the other side of the Michigan Central Station, which made news because it was recently bought by, Ford Motor Company bought this great train station. They're renovating it, so there's some hot real estate in Corktown and Southwest Detroit. I am a graduate of Wayne State, and I did my residency at Oakwood Hospital's Family Medicine Residency Program in Wayne and at Oakwood, now Beaumont, of course. This is me in my office. We were featured in Channel 4 News talking about our healthcare delivery approach. And I'm really here today because I believe that healthcare should be affordable and accessible for everyone. And this is radical because, as you know, our current system is built up where there are these gatekeepers between patients and their physicians, and not everyone has access to affordable healthcare services. This led me to speak at TEDx Detroit. It also led me to write a book about this subject. After I wrote the book, I received a couple of awards, the Vanguard Award, like Dr. Nodem had mentioned, and I got invited to the White House after writing the book, which is something I had never imagined, something I would never have dreamed of happening, but it happened. I was interviewed on Flashpoint in this regard with Devin Scillian, and also an ER physician, Frank McGeorge, who had some praise for the idea as well. So let's talk about what's wrong with our primary care system currently. So 54% of doctors say they are burned out. So who's felt symptoms of burnout? Have you guys talked about burnout? Okay, great. People have talked about burnout. Everybody knows what these symptoms are like. I really dislike that term. I'd rather use like a power failure, because burnout implies that like a light bulb has burned out, like you, the individual doctor, has burned out. But really, we know that it's this system that we're in of seeing more and more patients in less and less time that's really wearing on us and causing that moral harm or moral injury. 88% of doctors are moderately to severely stressed. You're probably among them, being in your residency here and taking care of some challenging patients. And 59% of doctors wouldn't recommend a career in medicine to their kids. And there's several factors that are pushing doctors to feeling this burnout. Let's talk about longer work days, higher student debt loads, less time with patients, and then burdensome documentation requirements in your EMR. How much time are you spending on average documenting patient interactions in your EMR versus talking with your patient face-to-face? Anybody throw out some numbers at me? How many minutes per patient are you charting? 2-to-1 ratio of charting to, yeah. So there's some studies that show that doctors are spending less than half their time actually talking and taking care of their patients, and more than half their time on documentation requirements. So not only does burnout affect doctors, but it affects their patients. Research from medical economics, research solidly correlates physician burnout with disruptive behavior, increased medical errors, lower patient satisfaction scores, and increased risk of malpractice. In addition, from the patient perspective, you have patients that wait a long time to see their doctor. Who knows the average wait time to see a primary care physician in Detroit? Average wait time to see a primary care physician. How many days? 95 days is a guess. Anybody else? 45, another guess. 6 months, that's a long time. So the average in Detroit is 24. Boston has the longest. They have 109 days between you making your appointment and getting to see that doctor. And even worse, once you get there, you may not know what this is like, but maybe your patients know they might wait 30 minutes to an hour to only see you for that 5 or 10 minute appointment slot. High patient volumes. So does anybody know that, like, when you graduate, let's say you're practicing general internal medicine, how many patients would you have in your panel on average? In your panel, yeah. So Dr. Nodem said 20 to 40 patients a day, which is accurate, right? You're going to see 20 to 40 patients a day. How many in your panel? 1,500, reasonable. That's low. But the average panel for a primary care physician in the United States is 2,400. So you're going to have 2,400 patients. On average, you're going to see 1% of your panel each day. So 1% of 2,400 gives you 24 patients a day, right? And that's your typical workflow. So that comes out to a patient every 20 minutes if you're working an 8-hour day, 9 hours with a 1-hour lunch break. Who here gets a lunch break? Okay, no hands? Okay, great. And because of this high speed of this flow of patients through your clinic. The Annals of Family Medicine revealed that patients only receive 55% of the recommended chronic and preventive services. So primary care docs struggle to manage high blood pressure, cholesterol levels, blood sugar levels, and other chronic conditions effectively, and we're not ordering the screening tests that we need to. And so I want to repeat something twice here. This is not the fault of the individual doctor. You know, this is not your fault. This is not the fault of the doctor. You know, it's a system that we've created of volume over value. Volume over time with your, volume of patients over time with your doctor. So we've talked about this already, spending more than half of your time working on charting. So to summarize, being a primary care physician is like trying to catch sand, right? And each grain of sand represents a concern of one of your patients. Maybe a mammogram that you need to order, or a daughter's sore throat, or a grandparent's dementia, or a sibling's chest pain, right? These are the concerns that our patients have, and the higher the volume, the more grains of sand are slipping through our fingers. So this is where I kind of go on a limb here. I'm saying we're losing the meaning behind what it means to be a physician, because being a physician for me is spending time with my patients, listening to them and understanding who they are, where they're going, and what steps they need to take to get healthier and to live their best life possible. So we're losing that ethos of what it means to be a doc. And there's a Japanese term for this. It's ikigai. And if you take a look at this graph, you guys are probably ending up somewhere in this bottom section. You're great physicians. You're doing what the world needs. You're meeting a need, and you're getting paid for this. But maybe in this rapid pace of taking care of patients, you're feeling comfortable, but perhaps feeling empty and not able to be the doctor that you want to be. So I'm going to talk about a system where we can kind of right some of these wrongs and get people closer to this sense of ikigai. All right, so let's define direct primary care. Defining direct primary care is really about developing a relationship with your patients and using a membership model to get there. And the DPC model succeeds where the fee-for-service system fails because it removes those third-party payers and reduces the doctor's patient load. And it really simplifies workflow. So this is data from Hint Health. When I pulled this information, there were 750 doctors. This was about 6 months ago. Now there are over 1,000 doctors. And I widened out the map because there's actually dots in Hawaii and Alaska now. But these are all the direct primary care physicians across the country who are operating in this model of care. It is a membership model. Memberships range between $10 and $100 a month. The average membership is, they say the median average adult membership is $82 a month, and the median adult membership is $65 a month. And so defining this, we charge a periodic fee. We don't bill on a fee-for-service basis. So if somebody comes in for an appointment, we're not billing their insurance on top of that. And we have no per visit fee, or that per visit fee is less than the monthly membership. So let's say you charge $50 a month. Maybe you want to charge somebody $5 every time they come through so they don't abuse your service. Not very few doctors do that, but it has been done. So the core belief behind all of this is value over volume. Value over volume. We want to make the membership costs worthwhile for our patients, their families, small businesses, and our community. The other guiding principle is price transparency. So when you look at the medical industrial complex from the patient's perspective, right? There are all these middlemen and barriers between patients and their physicians. So, for example, who here has heard of a PBM? Dr. Cellini, pharmacy benefits manager, right? So they negotiate on behalf of the insurance company with pharmacies and give member discounts. And up until recently, there was a gag order. If the cash price was lower, the cash price of the medication was lower than what the PBM had contracted for, the pharmacist could not tell you that medication price was lower, right? Couldn't tell you the patient picking up the medication. So a lot of these middlemen inflate the cost of these healthcare services. So in our DPC model, we remove these middlemen, we remove these barriers between patients and their docs, and then I take it upon myself to help people find the lowest cost for medications, labs, imaging services, and specialty consults. On a more human level, direct primary care is about offering folks assurance that they can reach me whenever they need me. So all my patients have my cell phone number, my email address, and they can call, text, or email me at any time. And I try to help them with whatever concern that they have. You see, in our current model, because doctors have so many patients, we have these things called urgent cares. And I would argue that an urgent care is a symptom of a failed primary care system. Because if you could actually get an appointment with your primary care doctor, there would be no need for an urgent care, right? Because you'd be able to reach your doctor and get in when you need to. As a caveat, each direct primary care practice is different. Everyone's going to handle their practice and their own business differently. People are going to practice in their own strengths and weaknesses. So just to compare and contrast the fee-for-service system with the direct primary care model, this is what typically happens when you bill out for a service. Is everybody familiar with the 99214 billing code? Okay, Dr. Nodem, they should know what a 99214 is, right? Okay, what's a 99214? You have to have a chief concern, or chief complaint. I use concern in my practice. Your HPI, you have to have 5 issues documented in your HPI. You have to have 2 to 10 a review of systems documented in the electronic medical record. And then you have to, in your assessment plan, you have to have 2 conditions managed, right? So, more or less, somewhere in that ballpark. I stopped billing insurance 2 years ago, so forgive me. So if somebody comes in with, for a visit in the insurance-based system, fee-for-service, they're paying $1, and there's some administrative costs of the insurance company, so they take 40 cents. And then because you have a high overhead clinic, you have a large office, multiple exam rooms so you can stack your patients, you have a medical assistant, a nurse, a phlebotomist, et cetera. Your overhead is 50%. So then you, the doctor, is left with 30 cents, right? So let's say you bill out for a 99214. Somebody comes in with a pneumonia. You give them azithromycin, and you make sure that their blood pressure is in check. You're able to bill out for this 99214, $130 that they might pay, or $140. $50 goes to the insurance company, $40 is left to the overhead, and then the physician is left with about 40 bucks. So because of this, docs are seeing more and more patients to maximize reimbursement because it's purely a volume game. In our model, we remove these inefficiencies and we remove these middlemen between patients and their doctors so that when they pay $50 for the monthly service, we minimize our overhead by having less staff and a smaller office. We can really deliver this service at cost, right? So one of the oaths that we took, anybody familiar with this one? Yeah, it looks Greek to you? Man, must be a long week, guys. Anybody? Any takers on this? Hippocratic oath? Okay, great. So primum non nocere, or first do no harm, right? And so in this DPC model, we have this ethos of first do no financial harm. We don't send folks to collections. The number one reason for bankruptcy in the United States is? Medical debt is second? Okay, I thought medical debt was first. Really blown. Medical debt, I believe, is first. So John Oliver, if you watched Last Week Tonight, he did a whole episode on medical debt, and he actually bought millions of dollars of medical debt and forgave it for folks, just to, for some PR buzz or whatever. But it's real. People go into debt, they lose their homes, their cars, et cetera, because of medical debt. So in my model, I'm trying to avoid this, so I don't send anybody to collections. We offer this monthly membership for a clinic, et cetera. So I'm going to break these down into different sections. First, I'm going to talk about lab work. So How much does it cost at the DMC to run, let's say, a lipid panel? $120? What's charged the person's, what's charged the patient? $80? Great. How much does it actually cost? $2? Yeah. Something like that. So these are prices that me, a single doctor, negotiated for in my practice. $6 for a comprehensive metabolic panel, $4 for a complete blood count, $6 for a lipid panel, TSH at $6, and hemoglobin A1C at $6. And I'm just one guy banging my head into a brick wall called Quest Diagnostics. Okay, nobody else gets that joke because nobody else has ever negotiated with Quest Diagnostics. But it's not fun. Some autoimmune type stuff, ANA $50, SED rate $8, C-reactive protein $6, CK $7, etc. And some hormone testing, $30 to run a man's testosterone level. Female testosterone is quite a bit higher, 173. Vitamin D level at 17, etc. So what I'm saying is that when you separate health care from health insurance, right, you can lower the cost of care when you start paying cash for services in the marketplace. Because we've introduced third-party payers like insurance companies like the Bucas of the world, Blue Cross, United, Cigna, Aetna, and Medicare and Medicaid, patients or individuals have become price insensitive because it's through a third party. So you're not seeing, it's like a black box. You can't see actually what things cost in the marketplace because there is no free marketplace. It's all inflated by these third-party payers who give a discount. So maybe you're billed $120 for a lipid panel, or $80. Let's just go with 100. It's right in the middle. And your insurance company covers 80% of that, and you're left with 20% of it. You're still paying $20 for a test that costs $6, right? So another thing that we do is we lower the cost of medications by buying them at wholesale. So this was the list. Steve Garagiola had a relative. He's a broadcaster with Channel 4. He's like, my family friend or relative takes these medications. How much would they cost in your clinic? And so I have in my hands a bottle of metformin, 1,000 tablets, 500 milligram, one of the most common drugs on the market for managing diabetes, of course. And so if you're taking one tablet a day, this is $16 for this bottle of 1,000 tabs. So how many cents a pill? $16 for 1,000 pills. Yeah, 1.6 cents a pill. 1.6 cents a pill, okay? So when I fill a 30-day supply for this, you're looking at 45 cents for your metformin. And if you're taking it BID dosing, you're looking at 90 cents. I've got 500 of sertraline here, 100 milligram tabs. This one was about $14, so let's see, doing my mental math, about 2.8 cents a pill. I brought some. Okay, so who sells them in bulk? You can go to Andameds. There's also Bonita Pharmaceuticals, etc. Andameds is out of Florida, the largest wholesaler that sells directly to physicians. There are other larger wholesalers, but you have to be a pharmacist. And so the next question I get is, how can you possibly do this? Like, you're not a pharmacist. Well, through LARA, through the state of Michigan, you can apply for and obtain a physician's dispensing license. $80 every, I think, 2 years. I just renewed it, so 2 years. $80 every 2 years, you can wholesale any non-controlled substance, right? So I carry about $5,000 worth of medications in my pharmacy. I think there's 300 drugs that I carry that I use commonly. Here's a list of some of them. I've got lisinopril, 10 milligrams. I didn't bring it, but 1 cent a pill. Amlodipine even crazier. Amlodipine 5 milligrams, calcium channel blocker, very commonly used. This is 0.9 cents a pill. So I just filled a 90-day supply for somebody and it was 81 cents. right? And typically, when you go to the pharmacy and you buy this, you're paying a $5 or $10 or $20 copay for one medication. So I have folks who come through our office, they're taking, I don't know, 4 or 5 medications. I'm saving them the cost of their membership. This gentleman, a 60-year-old man who had poorly controlled diabetes, hemoglobin A1C of 12%. He was hospitalized, his blood sugars were in the 400s, and he had a folliculitis on his right hand that became infected. Abscess, he needed surgical debridement in the hospital. They managed his blood sugar in the hospital with insulin, and he had no primary care physician, hadn't been to a doctor in years, and the care manager referred him to our office, and we were able to get his medications. If you can't read this from up top, lisinopril, 40 milligrams, 90 tabs, $2.70. Simvastatin, 90 tabs, $4.50. Metoprolol, 100 milligram, BID dosing, 180 tabs for $4.32. So for about $11, $12, we got him his 3-month supply of medications. And Novo Nordisk, they're the drug manufacturer for Tresiba and Novolog. They give free samples to physicians. All you need is an NPI number and you can apply. And they'll mail you insulin. So I got this guy, Tresiba and Novolog, for free. And he wasn't managing his diabetes for years, or in denial, or not being proactive because he didn't have any money. So I'm lowering the access point for healthcare because the cost barrier is no longer there. This guy works driving a truck, ironically delivering medications to different pharmacies across the region. And now he has, a well-managed, his hemoglobin A1C, so I started seeing him in September, his hemoglobin A1C is now 8%. It's not great, but we're getting there. And he's writing down he last came to see me on the 5th, and he's writing down his blood sugar numbers. Fasting in the morning, he's looking at 149, 139, 135, 111 on the 2nd. There you go, guy. Great work. Another core belief is same day, next day appointments. So a lot of people put off taking care of themselves because it does take 24 days to get in and see your primary care physician, or you can go to the urgent care, see somebody you've never seen before in your hour of darkest need, or you can go to the emergency department. You can have a bill for $1,000 for a medical service. So when you're a patient and you have something go wrong with you, it was funny. This night I was at the gala and I was talking with Dr. Cellini, and I rudely said, "Excuse me, one of my patients is calling me." It was about 10:30. I stepped aside, and they sent me a couple text messages as well. "Hey, doc, can you see a staff member to stop a bleeding finger?" And then I called them, or they had called me, and I said I can be there in 20 minutes. And it took me about 30 minutes to get out of the place. I got down there, and they really just cut off the tip of their finger. And so I just applied some, I'm blanking on the name of it, Drysol to the tip of the finger to stop the bleeding. Now this saved them a trip to the emergency department and also a $1,000 bill, or maybe $1,500 or $2,000 for one of the employees that works at this restaurant who's uninsured and is a member of our practice. So we guarantee that we'll see them as soon as I humanly possibly can. Another thing that I do is I leverage technology to take care of my patients. Excuse my dude, what's up, man, sort of vernacular here, but I'm just checking in with one of my patients in September 2017. Want to make sure that their smoking cessation is on the right track. So me following up a week later, how are you doing with your smoking cessation? Still cigarette free, I'm breathing way better, and my self-esteem is pretty high. So the essence of direct primary care is building a personal relationship with your patients, right? That's what I'm trying to restore in my practice. This is a nice summary slide. I was interviewed in Business Insider, and the author of the article created this nice slide. Medical professionals, and this is family docs, sorry, there are internists doing this, but there are more family docs doing this. They say there's 130,000 of us, and there's about 1,500 doing direct primary care. I say it's closer to 1,000. Patients per doc, 2,400. In our model, we typically cap around 500 patients. Cost per visit depends on your insurance plan, but in our model, it's free with the monthly membership, often about $50 a month. How long are your visits? So in the fee-for-service, you've experienced this maybe 15 minutes, 10 minutes, 20 minutes if you're lucky. If they're a post-hospital discharge appointment, you can squeeze out a little bit more time. Salary is based on our membership fees versus I went without a guaranteed salary for 2 years now because I feel passionately about starting this up. We don't bill or use insurance. Costs of labs and meds are at wholesale or at cost, whatever we can negotiate. It's our summary slide. So I just wanted to name a few practices locally. I'm not the only person doing this. And actually, Dr. Chad Savage is an internist. He went to Case Western, and he started a direct primary care practice. After 10 years of practicing in the Ann Arbor area, he was really dissatisfied with the amount of time that he had with his patients, not enough, and with the documentation and prior authorization hassles that he was being faced with. So he now has a partner, Dr. Cook, who's with him. Dr. Amat is also an internist, and she's in Grand Rapids. Dr. Hellman is a family physician. He was practicing for 2 years in Oregon, got really dissatisfied in the fee-for-service model, and he started up in Troy. Dr. Schumacher, again, this is a guy who was practicing for 15, 20 years in northern Indiana, and he converted his practice to a direct primary care model, and he filled up in about 11 months. In 11 months, he went from 0 patients to 600. Really impressive. One of my mentors is Dr. Clint Flanagan. He's in Colorado. He started Nextera, and they're doing something unique in that they're contracting with larger employer groups and setting up doctors and physicians around servicing those employer groups while still accommodating individuals and families. And then, I have a smattering of colleagues posted here. There are hundreds of doctors doing this successfully across the country. Okay, so you might be thinking, okay, that's great, Dr. Paul, it's fine. You get to spend time with your patients, but how could I potentially do this? And there are some barriers to starting this. You are taking a risk. You are starting a business. There are no guarantees in the free market. So it will take money, but so I'm going to go through these challenges first. How much is your EMR going to cost? How much is the malpractice going to cost? There's uncertainty. It seems risky. Maybe you don't like the concept or think it's unethical to charge your patients money for medical care. Maybe you're scared to give up certain benefits like a guaranteed income or retirement plans, or maybe your spouse or significant other has concerns about this model. So this was a sample cost when I first started out. These are my costs for the first 1 year of my practice, so average over 12 months. I pay $300 a month for my EMR. Does anybody know how much it costs to implement Epic in an outpatient clinic? Any takers? $1 million. That's a Dr. Evil quote. Yeah, $1 million, $500,000, $1 million, $500,000, $1 million. In the hospital system-wide, how much did it cost the DMC to go with their EMR system? Epic was $6 million. Great. These things are expensive. So actually, a doctor who started a direct primary care practice created a DPC-centric EMR. No billing codes. It does inventory within the EMR, and it is a free text. I literally just write a SOAP note for my patients in my EMR. A free text, it takes me about 2 to 3 minutes per patient to document that. And it's even better. I have a student with me today. His name's Rob. He's from Duke University, and he's a nurse practitioner student. He's working with me in my clinic this month. It's even better when I have a student with me. They get to learn how to write notes, and then I just have to read their notes at the end of the visit. It's a pretty amazing system. All right. Additionally, I rent a small office. It's $600 a month. My malpractice insurance is $450 a month. In this first year, I was ordering about $500 in meds. I was doing about $1,000 a month in lab work. I would go to conferences, so I'd pay for that through my business. I'd make some donations to different charities, et cetera. So I did this break-even analysis. I know you guys aren't business people, but these are really easy to do. You plug in your fixed costs your variable cost per member. So I had $10. My membership price was $50. And then I was projecting 15 new members each month. And it got me to break even around, my break even where I wasn't losing money was around 60 patients. And then I was making my residence salary back at about 200 patients, right? And it took me about 15 months to get there. In 2 years, I'm now at 430 patients, active members in my practice. So my second year, this is kind of average again. Again, a lot of these prices are fixed. Moving to a larger office, I'm going to be paying more in rent. Maybe hiring another person would be another, like a medical assistant would be like $3,000 a month. You get the idea that the monthly cost would be around $10,000. Again, another break-even analysis at a higher fixed cost rate. How long would it take you to make the set income or salary that you would want to make in this model? And it's really up to you. You can set your prices. You can say, I only want to have 300 patients and I want to charge everybody $80 a month. Or I want to have a target of 600 members and charge everybody $50 a month. Once you start doing the math, it kind of makes sense in that way. So there's risk involved. I say that it's not a leap of faith, but like a leap of determination. Doctors are really smart and know what they're doing. So if you wanted to get in this model, it's relatively straightforward. You have to follow some certain steps like writing a business plan, networking with other direct primary care physicians, attending conferences, reading books. So, one of my friends in the movement, Landon Rousseau, he started a podcast where he interviews successful docs. There's other books that have been written. One of my colleagues, Doug Farrago, wrote How to Start a Direct Primary Care Practice. The AAFP has a member interest group. I don't know what the Internal Medicine Association is doing around direct primary care, but maybe you could start a member interest group. And then you can attend conferences and network with colleagues. So this is my office when I first started, just a one-room office, Southwest Detroit. We face Verner Highway, right behind the Michigan Central Station. This is what it looked like when I first saw this space. This is what it looks like more or less now. It's my space where I take care of my patients and have the time and space that I need to be the physician that I was meant to be. And that's it. Thanks so much. All right, so I know folks have a ton of questions. We'll go rapid fire. I'll repeat your question, perhaps, or we'll use the mic.
I have a few.
Okay.
First and foremost, thank you very much for this insightful presentation.
Thank you.
A couple questions. What is your response to that patient that comes to you that says, I love your concept, I want to save money with my medications each month, but I don't even have $5 to pay you per month?
Sure. So I do have patients like that who do pay me. I have a few patients enrolled for $1 a month. Because, I'm in Southwest Detroit. Our building is Detroit School for Digital Technology. Part of their ethos is helping returning citizens, people coming out of the prison pipeline, find employment and meaningful work. So I've done a lot of pro bono care. Each month I probably write off about $1,000 to $2,000 in bad debt, unpaid bills. That's just part of being a physician. People want medical services, but sometimes won't pay. It hurts more when you're directly taking care of those transactions and it's not farmed out to a third-party insurance company. But trust me, as an internist, you're making $1 million in downstream revenue for your health system, hospital system. So I went into this, if you go into this, believe that you're worth $1 million a year, and that will kind of help you set your mindset around this. And for me, forgiving a few $1,000s a month isn't a big deal. Doing pro bono care for some of the guys who are coming out of prison with felony records is something that I feel passionate about, so I do it.
I also did some real quick math. There's about 325 million in the U.S. You said if we have people with, let's say we expand this nationally, with only 1,000 patients per panel.
Yeah.
And that's on the high side. Many people have far fewer.
Sure.
Currently, there's about 245,000 primary care physicians. given a population of 325,000, we need, or 325 million, we need 325,000 primary care providers. Where are we going to get an additional 100,000 providers in the U.S.?
Sure. Well, I'm not, let's see, where to take this one. So we're projecting a shortfall of physicians. I think we're going to be short by, they're always saying like by 2030, we're going to be X number of physicians. So I see medical care, primary care, not as a numbers problem, but as an efficiency problem. We have enough primary care physicians to do the work. What we have currently as well is an inefficient EMR system, inefficient delivery systems where that healthcare is bogged down by time we're spending charting and not taking care of patients. So that would be my answer to that.
All right, I have a quick question. So you're charging different amounts per month based on patients' ability to pay?
Based on age.
Age.
Yeah.
But you said that you have someone who's a prisoner who, or just recently released from prison, and you're going to charge them less because they can't afford it.
Sure.
Are there any concerns when you start to do that of implicit bias? That this person you're charging less and this person you're charging different, so that there could be concerns related to people not having the same access in that way, really related to bias?
Sure. I mean, these are really on case-by-case basis, and a lot of the people I take care of work in the building that I'm practicing in, so that I just know them on a personal basis. So, you know, the guy who works in the building who says, you know, I'm really concerned about my kidney function because in prison they told me it was bad. Can you run a couple tests for me, right? I'm trying to make this affordable and accessible in a way that the insurance system is not. He's not even qualifying for insurance because of his status of being formally incarcerated at this point. So it's really a hindrance to him getting the care that he needs. So I guess in the insurance-based model, physicians are often guarded from patients who can't pay for care because their front desk simply will not allow them into the practice, right? For me, it's a lot of personal conversations with folks. So I guess, is there some bias? Perhaps, but I'm really trying to be just and fair in my delivery of care in that I'm trying to accommodate people who wouldn't qualify for insurance. Or if you don't have $50 on a case-by-case basis, I can help you out with certain things.
Thanks a lot. There's really a lot of neat things about this practice, but I got to tell you, I'm kind of upset that you interrupted our visit a couple months ago.
Yeah,
to go fix that finger. I hadn't seen you in a while. So in all seriousness, what is your risk of burnout of being available to 500 people around the clock 24/7?
Sure. I would say I feel far less burned out than I did during my residency. I come in genuinely feeling good 9 days out of 10. There are some stressful things that can happen because I am running a business and trying to leverage capital to build out a larger office and taking care of folks. But to be honest, the number of after-hours texts that I receive is minimal. I receive probably about 20 text messages each day from my patients, and it's usually to coordinate care, set up appointments, have a refill called in, et cetera. But most patients are respectful of my time in that they text me during the day and I take care of it during the day. The other thing I didn't mention is the typical doctor has 2,400 patients. In my practice, I'm at 430. When I see 1% of my panel each day, it's not 24 patients a day, it's 4 patients a day. And so my typical work day, I'm seeing about 5 to 10 at most patients each day. And I am able to spend 30 minutes to an hour with each of those. So even if I spend an hour with 4 of my patients or 30 minutes with 8 of my patients, I'm working for 4 hours a day face-to-face taking care of my patients. And then I have an additional 4 hours, typically like 2 to 3 hours, to take care of administrative things like responding to text messages, emails, applying for a loan, working with my architect on designing a new space, whatever it may be. But I can really get that work done during my working day and I don't have to take it home. The other thing is, how many people here are doing pajama notes? Anybody taking their work home after a long day at clinic, walking out of the office, I'm done with this, I can't even chart today, I'm gonna do this at home at 9 o'clock after I put the kids to bed. Yeah, I'm seeing some people nod their heads. Anybody, come on, give me something here, guys. Help me out here. Please, I'm begging you. Yeah, I think just as being a physician is difficult because you're taking care of people and you want to do the right things for folks, you know, you're going to take that home with you in some ways. I have the luxury of having all my notes done during the day, especially when I have a student with me. And then I have the luxury of having enough time to be responsive to text, emails, and really triage care. So like, for example, somebody sent me a text of their genitals the other day because they had an HSV outbreak. What is this, doctor? You have herpes. I'm sorry. So we made the diagnosis. We discussed it together. I sent him the CDC information. Hey, read through this. If you have any questions, let me know. He did, and then he sent me some follow-up questions. How many sexual encounters on average does it take to spread this? What do? I have daughters. I don't want to give it to them, right? So we talked about all this stuff via text, and he came in the next day. We drew his blood. We checked for some other STIs, and we gave him Valtrex. You know, Valtrex for like, I think it was $10 for all the Valtrex that he needed, right? So because I'm able to triage things and take care of things by text, I'm able to spend more face time with my more complex diabetic, hypertensive, CKD patients where they need more of my time and attention, right? So that's a long way to answer your question. But in terms of burnout, I feel good every day and I'm able to take time away. And if I need to schedule like a morning or afternoon off, I can just not schedule patients for myself that day or that half day.
Thanks again for your talk.
Thank
I have
you.
a question. So regarding those patients, they will not have health insurance for the most part, right? Because they're doing this direct patient care model. So what happens when they get admitted to the hospital? Because at some point they're going to have to be admitted for some
Sure.
disease or another. Or
Sure. The majority of my patients have health insurance. So separate in your mind health care and health insurance. They're two completely different things, right? So people choose Plum Health because they want health care. They want to be able to text me, email me. They want to have the time with me, right? So about 65% of my patients do have some sort of insurance. If my patient is admitted to the hospital, I often make social calls. I had a patient admitted to the hospital and I met him in the ER. He was admitted at 4 o'clock, or he was brought to the ER at 4 o'clock. So I met him there at 5:30 when I had finished seeing my other patients and went home after that. But it allows me to communicate clearly with the ER physician. It was at Henry Ford this time. And then, you know, once he's admitted, I get the number of the attending or the hospitalist taking care of them, and I call them. You know, just like at your outpatient practices, if you're doing internal medicine outpatient, medicine's moving to siloed care, correct me if I'm wrong, where more physicians are dedicated to hospitalists and more physicians are dedicated outpatient specialists, right? I'm an outpatient specialist. So if I can, I will make a social visit and I'll definitely call your doctor who's taking care of you and get the best information possible. As for payment, it'd be the same if they didn't have me. Let's say they're uninsured and they didn't have me. They'd still be uninsured, but they wouldn't have the primary care coordination or somebody advocating on their behalf when they are hospitalized and somebody to visit when they're leaving the hospital, right? Because like for example, the diabetic with the hand infection, if he was uninsured, because he was uninsured before he met me, and then he's sent to an insurance-based doctor, he'd be like, I'm not gonna go, because I'm gonna spend $200 cash to see this guy, because that's the cash price to see the doctor, and then they're gonna write me for all these scripts that I can't afford, so why bother, right? So in my model, even if you are hospitalized, maybe you'll get a big bill, or maybe they'll put you on charity care, and then I'll try to do my best to coordinate care when you leave that facility.
Hi. Thank you very much, Dr. Thomas. Very enlightening. My
Thank you.
question is your model applicable to the rural environment where the distances are greater and you don't have the concentration of patients in your immediate area?
Yes. So I'm a rare bird, just as a general rule, but you know, starting a direct primary care practice in an urban, underserved community, you know, there are only a handful of us doing this across the country in that sort of setting. The majority of folks are in suburban, wealthier neighborhoods and in rural areas. In rural areas, you might be the only doctor in town, literally. So, you know, if you have a town of 2,000 people, you only need 500 to be successful. So I've seen physicians just absolutely crush it where they start a practice in rural Kansas and in 6 months they're completely full because patients have been wanting to have somebody in their community. And if you think about the ethos of folks in rural communities, we kind of get to this red state, blue state argument, but folks may be in line with, I don't want the government having anything to do with my health care, so I'd like contracting directly with you because you're not billing anybody, you're not sending this information to anybody. It's all confidential between you, my doctor, and me, the patient. So, in short, rural practices do really well in this model.
Is the potential, we talk day after day about disparities in healthcare.
Sure.
Does this model have the potential of widening that gap of healthcare disparities and those that can't afford this monthly subscription fee?
Sure, you're talking about, will this, if, let's say more doctors go to this model, they're not billing or using insurance, perhaps there will be less doctors taking care of Medicaid patients, right? That's kind of what it gets down to. I think no, because I'm going to say this, people are not choosing primary care medicine, primary care internal medicine, primary care family medicine because it's not a rewarding practice in its current state. Who wants to see 30 patients a day for 5 to 10 minutes per patient and be among the lowest paid specialists? It's not appealing for it's not appealing for medical students, it's not appealing for residents. How many internal medicine residents are in the room? And how many, leave your hand up if you're considering specializing, not doing general internal? Okay, right? Because it's not gratifying, it's not rewarding. It's better to be the ultimate person solving the problem, doing the scope or what have you. So I'm excited about this model because it's exciting for students and residents to hear that you can practice medicine on your own terms, make good money doing it, set your own hours, prices, etc., and have control over your future and your destiny rather than being beholden to a third-party payer. And I think if we get this message out, there are going to be more people, more doctors choosing primary care so they can practice like this.
Thank you, Paul. Thank you, Paul. My question is, what will happen to direct primary care if we move to a universal health care system?
Yeah,
what do you think, what will happen? Is it at risk of becoming more of a concierge type service, or what are your thoughts about that?
Oh man, my real thoughts?
Your real thoughts.
Oh man, can I say, oh man. Plastic surgeons, right? People are always going to be wanting to pay over and above their insurance for plastic surgery. Facial surgery, other things that I won't say. And then let's talk about LASIK. People are going to want to have LASIK surgery where they can pay a physician money to not have to wear glasses or contacts. So I think as long as the American free market exists, people are going to be wanting to pay over and above what's covered for better quality, better experience, transparent pricing. You had a question up there? Anybody?